Good morning. I'm Sarah Waddle, State Director with AARP Indiana. I want to welcome you to this important discussion. Today, we're going to be speaking with many AARP members across Indiana, and we're going to be joined by our special guest very shortly. In just a moment, you will have the opportunity to hear about what we can do to make our medical system more age-friendly for Hoosiers across the state and how you can advocate for yourself when receiving care. If you've participated in one of our telephone town halls before, you know that they sound like a call-in radio show where you have the opportunity to ask questions of our guests. If you would like to ask a question during this call, you can just press *3 on your telephone keypad, and that's going to connect you to an AARP staff person who will note your name and question and get you placed in our question queue. And today we're going to get to your questions at the end of today's discussion. You may want to grab a pen and paper as well, because I'm sure lots of great information is going to be shared today. So you're going to want to take some notes. I also want to welcome those of you that are joining us virtually through Facebook. Those on Facebook will be able to hear the conversation and view the accompanying slides. And to ask questions for you all, you're going to use your chat function. And don't worry, we'll be share out with everyone on the phone and virtually where they can access the recording and the slides and all of the information from our conversation today. So today we are speaking with Doctors Diane and Patrick Healy. Doctors Diane and Patrick Healy have shared a 40-year journey in medicine and life. They met at Indiana University Medical School, completed internal medicine residencies at St. Vincent Hospital, and trained in geriatrics at Queen's Medical Center in Nottingham, England. Returning to St. Vincent, they founded what is now the Center for Healthy Aging, focused on clinical and social needs of older adults and their families. Dr. Diane served as medical director while Dr. Patrick led the geriatric fellowship program. Their work spanned inpatient, nursing home, and outpatient care alongside educating students and professionals and developing programs. Now that they are retired, they are anything but. They've launched Healy's on Aging Consulting LLC, continuing their mission to educate on age-friendly care, especially the 4 M's, which you are going to hear about in our discussion today. Both remain active learners and caregivers while enjoying family, fitness, food, and travel. For those of you that are just joining us, we want to welcome you to our important discussion today about making our health systems more age-friendly and how you can advocate for yourself when receiving care. A few instructions for today's discussion. If you're on the phone and want to ask a question, you can press *3 on your telephone keypad, and that's going to connect you to a staff person who will get your name and question into our queue. The Doctors Healy will get to your questions after they share some great information. For those of you joining via Facebook, you're going to hear the conversation and see the slides, and to ask questions, you're going to use your chat function. And again, at the end of today's call, we'll make sure everyone knows where they can get all of the information. Whew, that was a lot of instructions, but now that you've received some initial information, let's get to the conversation. Welcome, Doctors Diane and Patrick Healy. Thank you so much for joining us on this very cold December morning. Please introduce yourselves to our audience and share a little bit about yourselves.
Sure. I'm Dr. Diane Healy, and I'm here with my husband, Dr. Patrick Healy, and I think Sarah gave you a pretty good description already. So we worked in the field of geriatric medicine or taking care of older adults for 35 years each together. But as we retired from that, we still felt that, there's enough knowledge that all of us need to know that we started Healy's on Aging Consulting, which isn't about taking care of individual patients anymore, unfortunately, but it's about educating people so you can help advocate for yourselves, which is what we hope to do today, again, on the 4 M's and age-friendly care.
Yeah, and I'm Dr. Pat Healy, the other Dr. Healy. We practiced in a very multidisciplinary way for most of our career, but when the age-friendly concept came about around 2017, it really, changed the way we practiced. And, in our retirement, it's an opportunity to sort of keep pushing the concepts that we kind of helped pioneer as the age-friendly system got started, because we think it's so important to advocate for yourself and the special needs of the aging population. So it really changed our practice the last few years, and we're really thrilled to be here to introduce the concepts to you, because I think it's really, really important.
Well, I can say that we are super excited to have you here today. I'm very much looking forward to this conversation. And for those folks who are just coming into our call, this is your chance to hear from and ask questions of our guests, Drs. Diane and Dr. Patrick. It's an interactive call, so if you want to ask a question, you can press *3 on your telephone keypad. It's going to get you connected with a staff person who will get you into our queue. Facebook participants, you can put your questions in the chat function. Now, Drs. Healy, I'm going to turn it over to you so you can share with us about what we can do to make health systems more age-friendly.
All right. Thank you, Sarah. You can go ahead and put that first slide up there. Not that the first slide tells you a whole lot, except that we're going to talk about age-friendly care and you. Next slide. And it's important that you realize that this information is educational only. We're not teaching any of you to be doctors today. That would probably take a little longer than what this session will last this morning. And that individual treatment decisions must be made between you and your healthcare professionals. So really important for you to know as you hear some of the things that we're going to talk about here this morning. Next. So we're going to just not talk about this slide for a little bit here as I kind of begin to introduce the concept. And as Pat talked about, age-friendly care came into being a few years ago, and it is its own concept, but we'll come back to what exactly that is in a minute. It's important first to understand why we even have to talk about that, how we got there. Believe it or not, aging is new. It has never before happened in the history of mankind that populations of people age. We know of over millennia individuals who maybe you heard aged for many years, 50 years, 100 years, whatever, but it's new because in 1900, if you were born, the average life expectancy was 47 years. Now, if you're born now, the average life expectancy is 78, meaning that if you're born today, on average, you will live 78 years. That's a whole lot more than that 47 years in 1900. So the healthcare system really does not yet know how to take care of older adults in a way that is provides quality for everybody, that helps solve the things you're looking for because our goals change possibly as we get older, that's efficient. Why don't they do this? Because it's new. We don't know how to do this. So we are all doing it together, whether we're talking your healthcare team, whether we're talking you as a layperson, as a patient, as a business or healthcare consumer, or whatever the case may be, or even as a caregiver. So it's all new things we're discovering together. And so I think that, as we go along here today and we begin to give you things to help empower yourself to talk to your providers, it's not because they aren't doing anything incorrectly or that they're, glossing over things. They may not have the information yet. This is new stuff that we're talking about, and we're all figuring it out together in terms of the aging. So what happens with aging? When we used to die by the age of 47 on average, people would die quickly. They would die of an infection or an accident or whatever the case might be. Now we have medicine and science and things that have allowed us to live longer. And with that living longer, which is wonderful, that means that there is time to accumulate chronic disease. What's chronic disease? Well, any disease that lasts potentially 3 months or longer and is not cured by the end of that time. We could all name many of those things. If I had everybody on mic and name things, we could sit here for an hour or 2 or 3 listening to chronic diseases. So that's things like high blood pressure, high cholesterol, congestive heart failure, depression, dementia, hard of hearing, decreased eyesight, osteoarthritis, you name it, those are all chronic diseases. And there's no saying which one you might get, or two or three or four or five. Okay? There is no playbook that allows you in advance to know which things might happen. Now, we have ways to work at decreasing the risk of some of those things, like exercise and good nutrition and good health habits, etc. But things can still happen to us, even with the best of intentions and with the best of care. So as we develop these chronic diseases, that means potentially we're on more medications. And over time, as we develop more of these, diseases, et cetera, we may begin to have some changes in parts of our health that we don't necessarily think of as medical. What am I talking about? I am talking about your energy levels, your walking ability, your ability to just do things at the same speed you would have done previously, your ability to bounce back from a cold, from a pneumonia, from a hospitalization, from whatever the case might be. And as this goes on, as we're developing these chronic diseases, we might then begin to become frail, a word that I think we've all heard of before, but it's really kind of new in medical terms, this word frail or frailty. So when we have frailty, again, it means we are slower at moving, possibly slower at thinking. Doesn't mean we have dementia, but things are just happen more slowly. We're at more increased risk of falls, increased risk of needing a hospitalization or a nursing home placement. So things are changing. We also don't know by the time we accumulate these multiple diseases how treating one disease makes a difference anymore. When healthcare and medicine are looked at and tried to determine what's the best way to treat a disease like diabetes or whatever you want to talk about, they are usually looking at younger people who may only have one disease. They're not looking necessarily at 85-year-olds with 5 diseases. The research to do that would be way too difficult. So we no longer know by the time you accumulate chronic diseases whether or not the treatments that we would have done in younger years are going to provide you the same benefit, or maybe they might provide you more harms. Maybe those medications we have you on are causing you to be tired. Maybe they're causing you to not sleep as well, or whatever the case might be, so that the things we were trying to do may no longer have the benefit that we thought they once had. So it means that as we get older, we actually become more heterogeneous, more different from each other, depending on your medical diseases, depending on your social situation, your genetics, everything put together makes a big difference. So we have a continuum, basically. We have people who are 65, 85, robust, healthy, maybe 1 or 2 diseases. Those people are really lucky, and they should go about doing their health care and treatments just like they used to do. However, if you are accumulating these chronic diseases, you might not be feeling as well, and you might not get the benefits from the treatments that you would have had if you only had 1 or 2 diseases. At the opposite end of this spectrum are people who are at end stage of disease, whatever that might mean, whether that's dementia, congestive heart failure, cancer, etc., and that or your family and your care team know that you are dying. That's the complete opposite end of the spectrum from healthy and robust, and resilient is another good word. It's the people in between who we really are kind of talking about today that are beginning to accumulate diseases, slowing down a bit, things are a bit different, that maybe this age-friendly care that we're talking about and the 4 M's might play a significant role in your history. Which brings us to this slide that we're on here, this age-friendly care, or 4 M's, which came about in about 2017 when the John Hartford Foundation and the Institute for Healthcare Improvement said, as a country, we're not doing a very good job taking care of these older adults. Why not? What needs to happen? Our goals should really revolve around quality of care, decreasing risks, decreasing harms, and maybe even decreasing costs, because a lot of healthcare dollars are spent at end of life, and people don't necessarily feel better or appreciate what's going on at the time, even though all that money is being spent. So these two organizations came together and did some research and found out that the places in the country that were getting good outcomes in their older adults weren't doing anything alike, except they had four things in common. They all had the four M's. That is, as they combed through this information, what these places were doing. Again, they weren't working together. It was all just, by coincidence, but it's what needed to happen. So if we look at the first M, what matters? We're going to come back to all these M's and spend a bit more time. What matters is key. That is the part that Pat kind of mentioned earlier that was revolutionary to he and I, as we had been practicing for many years at this point. But asking people what matters to you was vitally important to each individual person. The second M, which we will talk about, is medications. The third M is mentation or mind. And the fourth M is mobility. These four M's all work together. They're not individual silos. Silos, part of our problem in the healthcare system is that everyone works in their own little field, and we don't always get the chance to look at a person as a whole. Okay, so we, even though we're going to talk about these M's individually, they all work together, and you'll hear some of that as we go on here. You'll also sometimes hear that there's a fifth M, and the fifth M that is talked about is multimorbidity, which just means lots of chronic diseases at once. Many people don't throw the fifth M in. We figure that's kind of a given if we're talking about this anyway. Next slide. So the what matters piece to this was a piece that initially, yes, we would talk about this with people, and that was the advanced care planning. So all of you ideally need to already have talked about this with family members. I know many people don't, but do you have a living will? Do you have a power of attorney? A healthcare power of attorney, business power of attorney? These things should all be in place. And if you do not have these, you need to go about getting these things done through a lawyer potentially. You can do these online, but they're always much more specific if they've been done through your lawyer. And this is also something I'm sure AARP can help you with. However, the piece of this that really is the newer piece is that is called the current care planning, meaning what's important to you today. If we were asking Mrs. Jones as she comes in the office today, what matters to you? What's important to you? You've led a good long life. Hopefully you've accomplished the things you want to accomplish and you're still enjoying life. But what do you want from the rest of your life? Is your healthcare giving you what you need? Is your healthcare burdensome? Sometimes we can have somebody having their whole day spent at home doing healthcare by the time you put your support stockings on, check your blood sugar 4 times, take your medicines 3 times, get the proper foods, et cetera, et cetera. You can spend your whole day doing healthcare and never get a chance to see your grandchildren or whatever it is that you are enjoying in life. So current care planning is really important. What's important to you? How do you do this, though? What do we need to do to make this happen? And this is, though, where you become your own advocate. You need to figure out what's important to you, or if you're if you are a caregiver for someone else, what's important to them, so that you can go about getting the health that you want. Next slide. One of the best places to do that or to start is on myhealthpriorities.org. Okay. This is a tool that was put out by the Institute for Healthcare Improvement and the John Hartford Foundation that allows you as an individual to work through your own thought process. And it gives you examples, but asks you questions. And you fill out online this sheet that then at the end, you kind of whittle it down to which one thing is most important to you and which things that you're doing from healthcare perspective are burdensome to you, which things are helpful to you. This is really important because I would guess that possibly your doctors have never asked you this, or your nurse practitioners, not because they don't want to, they don't necessarily know about this concept because it's new. So you need to help them. You need to be the captain of your own ship here. This is truly, truly important. And so if you do this, if you go online and you work through this myhealthpriorities.org, you can print out a one-page summary of what you've just done, and you take that to every healthcare provider you're going to, whether that's your primary care doctor, so you can have appropriate discussions, whether that's consultants, whether it's the physical therapist, whether you end up in the emergency department today, because you might not want all the care that they're recommending. You want to hear what your options are, but one of your options that you may need to say is, you know what? Thank you for telling me that we can do this whatever treatment, but does it fit my goals? Does it fit my what matters? And when people come up with what matters, it's not usually things related specifically to their medical care. It's related to their day-to-day, what they get joy from. You know, your what matters might end up being, I want to be able to, be at my daughter's wedding or my granddaughter's wedding. I want to be able to walk down the street to watch my grandchild get on the bus. I mean, it's things like that. I want to be independent and stay at home. Now, sometimes goals aren't always reasonable, and you might have to redo or rethink what your goals are. Sometimes those have to change, but you need to make sure that everyone that you receive care from understands what your goals are. So you're there maybe to see a new doctor, a new consultant, or in the emergency department because you have some real concerns and you need help, but it doesn't automatically mean that you want to proceed through a new scan or a new surgery or whatever. It's very much an individualized thing. So that's myhealthpriorities.org. Conversation starter kit or the conversation project is one that if you've never even begun to have these sorts of discussions with your family, even in terms of what end of life looks like, this is a website to go to help you get started. This is something that some people find very uncomfortable to talk about. And then the third one on this list is a new one. It's called My Health Checklist. And again, it's put out by the Institute for Healthcare Improvement. And it's a printable guide that can help you put together your thoughts before each doctor's appointment you go to. Some of it's repetitive from the My Health Priorities, which is okay, because in a sense, you might use them a little bit differently. One just for doctor's appointments, but the My Health Priorities for kind of overall bigger scenarios. So, these we would recommend at least get started on myhealthpriorities.org and just see where it takes you through. See if that really helps you. And see if that helps you, be able to communicate better, because you need to communicate what's important to you as you receive healthcare. Pat, anything to add there?
Yeah, so we started doing this in our office visits, and you wouldn't believe the funny looks we got when we were asking patients and families, basically what matters or what are your healthcare goals, and oftentimes they couldn't come up with them. But it starts a conversation. But it also allows me as the provider to know where you're coming from, because from my training, I want you to live as long as possible, but am I doing things that promote your goals? And we're here to say that what matters starts you advocating for yourself or your loved one. What really is important? What do you want to get from healthcare? And is healthcare, excessively burdensome? It's a great conversation.
I just made a point there that I want you to understand. We're not saying that as you do this that you're giving up on anything, okay? We don't know that some of the care is still necessarily most efficient for you, giving you the outcomes you're looking for. It's not that you're saying, okay, I'm done, I'm going on hospice. That's not it at all. It's what can I do to live life the way I want for whatever years I do have left. Okay, so that's really important. This is not at all about giving up on anything. It's about steering your own ship here so that you are getting the outcomes that you want. Next. So the next slide is medication. You know, medications have been amazing over the last 100 years in order to allow us to live longer. I mean, there are many things that we have available that's the reasons why we do live longer. However, we have to understand that as we do get older, our body's ability to handle these medications changes. So we may not tolerate things as well, or we might tolerate them differently as we did than when we were younger. We also don't know what happens again when we put 10 medicines, 20 medicines, whatever, in an 85-year-old person who's maybe now having kidney problems or heart problems or thinking problems or whatever. We don't know that these are still providing the same benefits they once used to. So, prescribing may need to be different for you as you get older. You also need to understand that as the patient, as I will call you, if that's what you are at this point in time, you are the only one that truly knows what medications you're on. Okay? Nobody else knows out there what's going in your mouth. Maybe a caregiver if your medicines are being actually given to you, but nobody else knows what's going in your mouth. And I know you think that these fancy computers the doctors have, have all that information. They don't. They are, I mean, ideally they do, but they're not always as up to date because it is cumbersome and very difficult by the time you talk about the trade name of medicines and the generic names, etc. So you need to keep a list on you at all times of what medications you're taking, what the dose is, how often you take them, and ideally what the medicine's for so that you understand what the medicine is for that you're taking. If you don't carry that list with you, it is very possible that there can be changes that occur inadvertently because no one really knew what you were taking. So please carry that list with you. That's one way you really are in charge of your own ship. You also, though, should ask for a review of your medications when you go in to see your doctor on occasion. Okay, it doesn't necessarily, ideally, they're looking at that list every visit, but you should ask for a review of that list at least once a year. Do I still need everything I'm on? Is it still providing the benefits that we prescribed it for? Is it interacting with anything else I'm taking? Is it causing me to feel tired? Is it causing me to go to the bathroom so much that I, can't sleep at night? Whatever the case might be, please ask for a review. And then sometimes what needs to happen is a new term called de-prescribing. Your doctor knows and nurse practitioners know how to prescribe, but de-prescribing or taking away medications is a new thing. And many times we would find that people felt much better as we did that in a very slow, kind of one at a time fashion, depending on what's all going on and what the symptoms are. But many times people feel better and sometimes live longer. Now, does that mean stop your medicines today because you don't like them? Absolutely not. You need to discuss this with your healthcare team because, yes, maybe some of the medicine might not be making you feel so well, but you don't know which ones can't be stopped and should be tapered or that might cause some other reaction if you stop it, etc. So please discuss that with someone else. But medicines are so important to help us, but they may no longer be what you need at certain times. There are also times when we have to be careful that we don't underprescribe because someone is, quote, old, all right? There are still plenty of places where treatments are needed, and we don't not prescribe just because of age. We wouldn't prescribe because of other situations that might be occurring. Next slide. So some resources on this. There are some medicines that we know are difficult in older adults that really shouldn't be used, or if they are, used with caution. So there's a website you can go to look at that. And the National Institute on Aging also has a tracking your medications worksheet, which can be very beneficial. So another nice resource for you to use. Next slide.
Okay, now it's my turn. I'm not just a pretty face up here. So I'm going to take care of the second or the third and the fourth M. Third M being mentation. All right, that is your mind. not just your memory. And, I need to emphasize that oftentimes in the crush of all the things that a physician or nurse practitioner has to look at medically, brain health issues often do not come to the fore. They're not mentioned. They're assumed to be fine. And I think it's extremely important as we age, as our brains age, that we do all we can do to maximize our brain function. And that is proper nutrition, hydration. Of course, many of you know that sleep is extremely important, something we didn't know, a couple decades ago, that sleep deprivation or poor sleep is actually harmful and can lead to cognitive dysfunction and depression. That's extremely important. Socialization is important. If you don't use it, you lose it. It's extremely important to look at brain health, and you may need to be the one who addresses that because it may not come up in a routine office visit, but you know how important it is to keep your brain healthy. The second part of mentation is dementia, depression, and delirium. Now, dementia is cognitive function that affects, or cognitive decline that affects function. Depression, we know, is a mood disorder. It's extremely common. Delirium, you may not have heard of, but that is the acute confusion that occurs with a new medication or with an illness. Oftentimes it's called acute confusion, comes on abruptly, is usually reversible, but it changes your cognitive function. And just need to be aware that someone becomes acutely confused. That's called delirium and needs to be addressed. Let your care providers know. Dementia and cognitive decline often is not screened for in office visits. And, I always contend that, the last person to know that someone is having cognitive problems or a dementia is the physician. Okay. And I'm as guilty as anybody. So if you see, or if you yourself feel like you're having issues with cognitive function and it's affecting your function, a family member or you're a caregiver of somebody, you need to bring it up because it may not be screened for, it may not be picked up by the healthcare team, and it's your responsibility to bring it up. Okay, the earlier you make the diagnosis, the better off everybody is. And secondly is depression. Depression, as we get older, is more and more common. Okay, now we don't like to talk about it, right? Because it's wrath of God or weakness or something. But in fact, it's some aging changes make it more common, right? But it also is very treatable and it needs to be addressed. So if your physician doesn't ask about it, and you're having mood issues, you need to bring it up or bring it up for your loved one. Okay, because it's all about maintaining independence and dignity, and depression is something that is treatable and can be addressed if you bring it up. But oftentimes it doesn't come up in the crush of all the other diseases that we're dealing with. So tell your medical provider if you're having or noticing changes in memory or mood, get screened for depression or dementia at least yearly. And if you have a sudden acute confusion, bring it up. Okay, it's extremely important your provider know that you have had an episode of acute confusion so it can be avoided the next time. So next slide. So resources, of course, Alzheimer's Association, and it's alz.org, is just an incredible wealth of information on cognitive decline and dementia. Highly recommended. The health and aging tip sheet on managing delirium, okay, acute confusion is just helpful. I think a lot of delirium happens and people don't realize it, okay, or they say, they're just old. But an aging brain is more susceptible to the side effects of medication or to the side effects of an acute illness. And many of you have seen delirium in the hospital, and it's called confusion. Well, it's delirium, and it needs to be addressed. National Institute of Mental Health has a website on older adults and depression, learn the signs and find treatment. This is something that, like I said, is extremely important and is very treatable, whether by medication or with counseling. And so make sure you advocate for brain health for yourself and for your loved ones, and let your providers know that if there are issues. Okay.
And I'm going to jump in real quickly here. Just on the thought that Pat talked about sleep for just a second, talking about how important it is. And that's absolutely true. Discuss that one with your healthcare team as well. Don't just run to the store and buy over-the-counter medications, because here's one of those places where the M's interact. If you run to the store and buy some Tylenol PM or some Benadryl or whatever for your sleep, you might now cause some mentation problems. You might cause that delirium that Pat was talking about. So talk the situation over. Don't just treat yourself for that.
Patio furniture restoration.
Oops, sorry, we have an incoming phone call. Okay, sorry about that. Life goes on. Okay. Okay, so the fourth M is,
Next slide.
yeah, next slide, thank you. The next slide is mobility. Now, when you identify what matters to most people, mobility is part and parcel to most of those goals, because the goals that we hear about are, I want to stay independent. I don't want my daughter to have to care for me. I want to avoid falling. All of these things are dependent upon maintaining mobility. And Diane talked about frailty, and frailty, is a situation where you've lost muscle mass, you're weak, you're tired, and you have difficulty just getting around and or falling. These are important aspects of mobility, and most physician offices probably don't address this. Now, the nurse bringing you in might notice that you're not walking as well, or you now have a walker, but you probably have to bring it up. My husband or my wife, or I am not getting around as well, or I have fallen, or I am afraid of falling. All these things are just as important as the medications that you're on and the treatments. Okay, because if I often say that it takes 10 or 15 years of tight controlled blood pressure to have beneficial effects on heart disease and stroke. Well, it takes 5 seconds to fall and break a hip, and we all know that people who fall and break hips, 25% are not alive a year later. So if you're having difficulty with mobility or you're worried about it, bring it up. Okay, why do we have to wait till somebody falls and has a fracture to call physical therapy or occupational therapy? We need to be getting these people involved, and we need to be adopting a lifestyle of continuing exercise. We always talk about young people exercising, but it becomes more important to exercise as you get older, because we have less muscle mass, we're more susceptible to injury, and so addressing mobility, and you probably have to bring it up for yourself or your loved ones, because you want to stay active and you want to maintain your independence. All of us know that. Maintaining independence, when I was asked what matters on my Medicare wellness visit, I said I want to stay independent, and so far so good. But we have to keep, again, exercise, maintaining mobility, and getting help to intervene when frailty or when falls begin or when we're having difficulty getting around is beneficial. And it may take you bringing it up. Okay, so ask how you can improve strength, flexibility, and balance, okay, physical therapy, and regular exercise, regular daily exercise. And the home should be monitored for, handrails and, cords and throw rugs, all that sort of thing is extremely important so that we can maintain our independence. Next slide. So the National Council on Aging has a falls-free checkup that you can do online. The Health Aging Tip Sheet, Home Safety Tips for Older Adults, and the an Aging Go for Life has an exercise and physical activity. Nowadays you can find out exercises that are beneficial for you, or you can ask your physical therapist, what kind of exercise do I need to do every day to maintain my mobility and maintain my independence? This is just as important as anything else that happens in a medical visit, but it may take you advocating for that, because it doesn't come up in the crush of an office visit where you have multiple chronic illnesses, multiple medications. You may have to say, I'm worried about falling. Fear of falling is just as bad as falling, because it promotes, immobility and weakness, and that is to be avoided. Okay. All right. So I think we've rounded up the 4 M's.
Except I'm gonna jump in again. Can't help myself. Sorry. So as Pat was talking about the mobility piece, again, these all interact. So when we talked about what matters, many times that what matters is I want to be as independent as possible. Well, if that's what your goal is, you really need to be working on that mobility. That's what it often has to do with. And in our experience, sometimes we would get that I want to be independent or be at home or whatever. But then when we recommend the physical therapy, somebody, oh, I'm not going to do that. Well, then maybe we have to rechange what your goals are, or maybe you need to do the physical therapy. So, finding out that what matters can sometimes help, you as the person receiving the care understand why these things are being done, or sometimes it may mean the healthcare team needs to back off depending on what that is. And the other quick point is that, again, we've kind of said really with each of these M's, they don't necessarily come up unless you bring it up. But the one place where it can happen, so if your doctor's office is offering you your annual Medicare wellness visit, I know many times I've heard that people really don't want to do those. That's your opportunity for these different M's really to come up. They weren't put in there intentionally, or at least marked that way when the Medicare wellness visit started, but it ends up the M's are all in there. So get your Medicare wellness visit. These things should pop out in there, if there are things that you need help with or having difficulty with.
Yeah, I think the Medicare wellness visit, people think that they want to have the big exam we used to do 20, 30 years ago. The Medicare wellness exam is evidence-based, and the 4 M's are in there. Okay, the 4 M's are in there. So, and that's the beauty of it. And I push back on people who say that they don't think the Medicare wellness visit is helpful. It is. It is very helpful, and I've had two of those myself. And you can see the 4 M's in there, and that's I think that's a real improvement in the care that we deliver to older adults, because it can be very different than the care that we deliver to 50-year-olds.
And if you're robust and healthy, that wellness visit might not show up anything, which is great, but it gives you a baseline, okay? So that maybe a couple years from now, there's a cognitive issue, and now you know that 2 years ago it was fine, or whatever the case might be.
Okay, so the benefits. So they have studied the benefits of age-friendly care, and they have shown some really interesting findings that I think is pertinent to all of you, and that is improved communication between yourself and the caregiver, or yourself and the providers, between the caregiver and the families, and you basically are on the same page. So there's improved satisfaction with care, improved relationship with the clinician, decreased medications, which is interesting, and also less time devoted to medical tasks. And I think as a physician, I often don't realize how much time I am asking you to put in to maintain, the regimen that we have agreed upon, and it can be burdensome. I mean, sometimes healthcare can be burdensome, and if it is, you need to bring it up. Don't stop things on your own, but bring it up with your provider team. Okay, so
next slide.
Okay, so we think that you all should be using the 4 M's and the age-friendly care paradigm to advocate for yourself and or your loved ones. Hopefully that message has come out loud and clear. So you now understand the concept of age-friendly care, how medicine may change its direction based on our goals and based upon changes that you're experiencing as you age, and use the 4 M's to better set the medical care that you want, rather than what me as a physician wants. We need to come. It's wonderful because you get this great sort of shared decision making. You have communication both ways, and it's not just me preaching to you what needs to happen. Okay, so pay attention also to frailty, right? Don't miss frailty. Someone is becoming weak and tired and can't get around and falling. Bring that up, because that needs to be, you need to intervene on that early. Understand that you need to be participating in healthcare decisions, whether it's for you or your loved one or the person who has cognitive dysfunction who can't make their own decisions. You need to advocate for yourself and your loved ones. We want the medical care to fit your goals. Okay. And again, I often say that, people, who are, in the group that we're talking about, they've achieved longevity. They have it. Now what? Now what? Because we don't have good medical evidence-based guidelines on what to do when people hit 85 or whatever, or 80. Okay, so your goals are very important, and we want healthcare delivered to you to be consistent with what you want it to do to maintain your goal, which is usually maintaining function. So in summary, the times are changing in medical care because we have so many older people with so many chronic illnesses, and you need to take an active role in how you want healthcare to be delivered to you. Again, it's a great conversation. We call it shared decision making, and hopefully this short, teaching session will allow you to feel like, okay, I can advocate for myself and make sure that the medical care is consistent with my goals. And my favorite "What Matters" of all time was when I asked my mom 10 years ago and said, "What matters to you?" And she was 88 at that time. She said, "I want to feel good every day." And that was her goal, and it continues to be her goal, and it has made us, made us tailor her medical care for her needs, which is, I want to feel good every day. So I hope you take the message that you can advocate for yourself by using the 4Ms, especially what matters, so that healthcare is delivered to you the way you want it and to maximize your goals.
Drs. Healy, that was some great information. I have a page full of notes here. And so just kind of diving in and having a little conversation here, I do want to remind folks, if you have questions for our guest today, please press *3 on your telephone keypad and get your question into the question queue. I have a few that have come in. That I'm going to go ahead and bring up. And the first one actually is my own question for you. And I'm curious, you talked about being captains of your own ship, which I think is super important. How, as a practitioner, how do you handle it when what you want is different than what your family wants?
So are you saying, Sarah, when you, as in the patient, or if the doctor's asking it, wants something different than what the family wants, which way are you going? The patient?
As the patient, the patient and the family want two different things. How is
want different things.
Do you?
Okay. Well, I mean, if the patient is cognitively, has the ability to be making their own decisions, that's what needs to happen, and that family, and this can be tough because families don't always agree, but the family, this is where, they need, you need to make sure the family understands it's theirs, their decision. And, if you guys need to talk more, maybe that's where they work through something together, like getting on that myhealthpriorities.org to work through that all together. So maybe the family can see where they're coming from. And I've seen it go both ways, where patient wanted all kinds of stuff done, or patient wanted nothing done, whatever, and families disagreeing. So you also have to see if you can come to the root of what's going on here. Why are they at such odds with each other?
We often say that, if the person can make decisions, they can be competent to make bad decisions. Okay, and that friction needs to be worked out, because if you're competent or you have the capacity to make decisions, that's the gold standard. No matter what, I often talk about the pushy daughter wants. It's not always the daughter, but they need to begin that conversation, as she said. But if you have the capacity, you are making the decisions. Good question.
Okay. Yeah. Thank you. Oh, okay. Be back there.
Man, I thought you'd start with an easy question.
Come on, where's the softballs?
Well, so here's one that has come in. How do you go about finding a good doctor that supports these concepts?
I wish that there were, that everyone was well trained in older adult care. We will never have geriatricians for everybody. So I think it all has to do with communication, making sure that you are finding a care provider that you can communicate with. So you both need to listen to each other. And as much as we said, advocate for yourself, we're not saying you go in and tell them what to do. We're saying you go in and you tell them what your goals are. How can we work together? So just making sure that it's someone you're comfortable working with. And by the way, that can be a nurse practitioner. I have many people fearful of nurse practitioners. A nurse practitioner can be just as wonderful to communicate with, if not better, because they're a nurse than a doctor. But yes, they can be great too.
Yeah, so I would just echo exactly what she said, and it may be word of mouth. Ask someone, do you have a physician who listens to you? That's probably the biggest thing. And we are very well trained in medical evidence that's based upon healthy 40 and 50-year-olds. But when you get in your 70s, 80s, and 90s, you need to have a physician or a provider, nurse practitioner who will listen to what your goals are. And I think communication is probably the biggest thing. Yeah.
Very good. Can you define acute confusion?
Yeah, acute. Yeah, and so acute confusion is, is kind of it's not a very good term. But basically, acute confusion means you wake up in the morning and you say, my head is foggy. I can't think, or I took a medication and I forgot. What happened. The hours before you took it. Look, acute confusion means a change in the mental status, change in memory that is acute. That happens suddenly over a short period of time, and may or may not be associated with something you can identify, like a medication, an illness. There's basically brain fog that happens very, very suddenly.
And you may or may not be aware of it, by the way.
That's true.
There may be someone around you that's aware of it, not you, which can be, again, another difficult situation.
But that's why medications, you have to be so very, very careful and take only medications that your providers are aware of, especially some of these over-the-counter medicines that can cause, quote, acute confusion. And people who have dementia or cognitive problems are much more sensitive to acute confusion, because you feel like, say their brain is on crutches and you throw out a crutch, and so they may experience acute confusion much more rapidly than someone who has intact cognition.
All right. Speaking of medication management in that regard, we have a question. I'm going to go to the phones. Ethel, do I have you on the line? Ethel's from Indianapolis.
Yes.
Are you with us, Ethel? Yes. What's your question today?
My question is this. I am now on basically about 4 medications for blood pressure. And when I asked the doctor about maybe, I forgot the word she had, but taking me off of the first one, she's kind of reluctant about it. But did I hear you say, yes, sometime they may need to do that?
Yes. Again, talk with them. Talk with your doctor. Ask them if you still need that one, since obviously it wasn't doing what they had hoped, and that they had to add more onto it. Or maybe even more importantly, if you feel that you have side effects from that particular medication, they may need to take you off of that. Now, having said that, blood pressure can be very hard to treat, and sometimes people do need 3 medicines anyway to get it treated. All these things, again, work together, that maybe the medicines aren't doing what they should because of some of the other things you're on. So it's a very complicated system, which is why we say, talk to your doctors about this. But I would ask again, but do not stop anything on your own. I would reiterate that.
What I would probably do is I would have somebody check your blood pressure standing up, not just sitting. And check your blood pressure after you've been sitting for 10 minutes, okay? And not just when you first walk in the doctor's door, which is what often happens. 4 medicines is a lot for hypertension, but check your blood pressure standing and make sure that when they take the blood pressure in the office that you have sat and relaxed. I am one who, when I was working, I had to say my mantra to calm myself down, because, my blood pressure would often be high in the doctor's office if I didn't slow down and sit down and relax. But yeah, bring up the conversation. 4 is a lot of that's a lot of pills.
It doesn't mean it's wrong, though.
No,
It
doesn't mean it's
means
wrong.
there's need for discussion.
Yeah.
Absolutely. Deprescribing, that was the term you used, right?
Yes.
We love the
I wrote that one
deprescribe. We
down.
love it.
Yep, absolutely. Well, kind of just to round out this conversation, can we talk about the future of age-friendly healthcare? How do we expand these concepts? How do we make this part of the everyday practice and not the exception?
I think that AARP has it right on,
Yep.
right here with this discussion today, because I don't know how many people are listening. I hope a lot, because it's everybody who hears about it that needs to be part of this social movement. And again, when the Institute for Healthcare Improvement and John Hartford Foundation started this, they called it a social movement. How does that happen? I talk to you, you talk to someone else, they talk to more people so that everyone becomes aware. And you know what? You're educating your own care providers as you do this, because it's not something that they specifically get in medical school. They're learning how to treat the blood pressure or the individual diseases, but the aging phenomena being so new, and there are so many things they have to learn, that unfortunately this is not yet. So part of your job here is that all of you listening today are part now of the educational team to educate everybody around you.
Very good. Good answer. Dr. Patrick, do you have anything to add to that?
No, I think she said it beautifully. What's interesting is you're going to hear more about it because there's the concept of the age-friendly ecosystem and how it's not just medical care, but also our public health, the infrastructure within our communities, all need to be adjusting to this age wave that is now upon us. Large amounts of older people who have different needs, and I think you're going to hear a lot more about it.
Very good. Well, I want to thank everyone for taking part in today's call. I hope you learned something new. And if you stay on the line, you're able to leave us a voicemail with questions or comments if we didn't get to you today or you were a little shy in asking your question. Also, I want to let you know that you can watch a replay of today's event on AARP Indiana's Facebook page. And for those of you on the phone, you can go there to see the accompanied slides. You can also find more information from today's call on AARP Indiana's website, and that's aarp.org/in. I would encourage you to go there, or just search us up on Facebook at AARP Indiana. I'd like to personally thank Drs. Diane and Patrick Healy for joining us today. It was a treat. As we near the end of our call, doctors, do you have any quick closing comments to share with the audience today?
Just a repeat of what we've already said. You guys can do this. You got this. If all of you can name us the 4 M's,
Yep.
What matters, medication, mentation, and mobility, go advocate for yourself, teach those around you.
Very good. All right. Well, thanks again to you both. We look forward to hearing from you again in the future. And one last thank you to all of you for joining and making today's conversation a good one. Have a great rest of your day, everybody. Thank you.